Dear colleagues and dear partners, we are lucky to have you at the third Prevent from Caries Symposium. Unfortunately, this year it is online, but we are lucky to be able to reach many people that we can. So we have in this symposium many renovated speakers that you would like, I'm sure, and some panel with also live presentations. So the first lecturer of today is Dr. Vicente Faus Matoses. He will present us his lecture about cooperation of orthodontics and restorative dentistry. So let me first introduce you Dr. Vicente Faus Matoses. He is the president of the Spanish Society of Conservative Dentistry. He is co-director of the Masters in Restorative Dentistry program and associate professor in the Dental Pathology, Conservative Dentistry and Endodontics unit of the University of Valencia in Spain. He is also the founder and the director of the Diploma in Aesthetic Restorative Dentistry at the same university. He has been awarded the prize for the best clinical and research work from the Spanish Society of Conservative Dentistry and has received on several occasions the International Consuro Prize awarded by the European Federation of Conservative Dentistry. He is part of the international team of DSD Masters, one of the most prestigious group of dentists in the world, whose members are chosen by other professionals as the best restorer throughout the technique of digital smile design. He is considered a benchmark in the field of conservative, restorative, and aesthetic dentistry and regularly participates as a speaker at national and international conferences. So welcome, Tito, to our symposium. Hope everything
Thank you very much.
Hope that the weather is
very much. Please.
And hope that you are healthy. So we welcome you on the screen to present your presentation, Cooperation of Orthodontics and Restorative Dentistry. So the screen is yours, Tito, and we're eager to hear your presentation.
Thank you very much for your presentation, Professor Sevnan Turkum. I'm very pleased and honored to be in your international symposium. It's a great, great honor for me. Thank you very much. And I hope you enjoy my presentation. Thank you very much.
We will. Please share your screen. Okay.
Let's go.
Yes.
So, as Professor said, I'm going to talk about ortho-resto interdisciplinary treatment in aesthetic and restorative dentistry. It's a great honor to share my screen today with all of you in this international third Prevent from Caries Symposium. As Professor said, I'm Vicente Faus from Spain. I'm a professor in the Valencia University, and all my work is done in cooperation with my brother, Dr. Ignacio Faus, who is also a professor at the university and also shares with me our private practice at Clínica Faus, which is placed in a town near Valencia, which is the third capital in Spain, in the east coast of Spain. This is our private practice where, as I said, we share our daily work as dentists. We try to carry on interdisciplinary work, and I would like to differentiate about multidisciplinary work and interdisciplinary work. Multidisciplinary is the work that affects different disciplines, but interdisciplinary is the work done in cooperation with other disciplines. So in the field of dentistry, we can say that if a patient comes into our office looking for a treatment, we are going as a team to cooperate between all the disciplines, not, for example, the one who does ortho does the ortho, and when the ortho is finalized, we go into the conservative or into the restorative field. But we work together because sometimes we need to cooperate. We need to begin with the ortho, continue with restorative, and finalize again with ortho. Sometimes that happens, and we need to communicate all this stuff during the treatment, but being planned at the beginning of the treatment plan. So we would like to differentiate multidisciplinary and interdisciplinary. When we put into the work our interdisciplinary treatments, we can achieve results like these that are very aesthetics, but most of all, they are functional and they are minimally invasive and very, very conservative. We can achieve this kind of results if we plan our treatments at the beginning and trying to do interdisciplinary treatments, not only multidisciplinary treatments. We try to be guided by some published articles like this one published by Professors Frank Spear and Vincent Cockett some years ago. And in the field of conservative dentistry, we try to keep or we try to be guided by other articles like this one of Didier Dietchi. This article gives us a guideline to do the treatment plan in 3 steps. The first step is a comprehensive etiological and clinical investigation, where we are going to see different, or the medical and dentist and dental story of the history of the patient. In the second step, we will plan and execute the treatment plan. And in the third step, we are going to do the maintenance of that treatment. But not also, he guides us in the steps we should keep during our treatment plan, but also he gives us a guideline to use different materials in different areas with different kind of destroyed teeth. So I'm going to try to explain 3 different movements we will need to keep during our treatment plans. These are 4 of them, maybe the more important. We are going to try to show 3 of them with different clinical cases, and trying you to put them into your daily work during the next days. We are going to see how can we use posterior extrusions to rise the vertical dimension. We are going to see how can we use the posterior intrusions to create occlusal space. And also we are going to see how to manage the anterior guidance, and how can we do a zenith equilibration for the aesthetic achievement. So let's begin with the posterior extrusions to rise the vertical dimension with this patient, Sergio, who is 27 years old. He came into our office saying that he was feeling a defect in the back side of his teeth, and also pain during chewing. These are the extraoral pictures where we can see a nice incisal display, and also a convex smile line which is something that we should try to keep. If we go intraoral, we can see attrition in this area, which is a part or the part of the teeth that he was expressing as a step in my backside of my teeth. This is the area where he can feel that step. And why he was feeling that? Because he was having an excess of anterior guidance, and that's the reason we should begin with an interdisciplinary treatment plan. This problem, the excess of anterior guidance, was also destroying his anterior inferior teeth. So if we go again intraoral, we can see that the teeth was located in the anterior area, only in the anterior area. There was not tooth wear in the posterior area, neither in the lower arch, nor in the upper arch, neither in the lower arch, only in the anterior teeth. So how can we manage this? What are we going to need to do here? What are our goals? We are going to have 4 goals. First goal is to eliminate chewing dentinal hypersensitivity, as a patient was consulting for. We will try to prevent future excessive dental wearing also. We will need to restore an efficient anterior guidance. And of course, we want to improve aesthetics, or at least maintain it. You will see why I say at least maintain it. One of the most renowned articles about dental erosion that is not dental attrition, I know, is of course different in his origin, but we can treat, as Dr. Francesca Bailati said in this article, if we take out the origin, of the tooth, where we can implement this kind of treatment also for attrition, not only for erosion. Our patient is an ACE class 2. It's a patient with dentin exposure on the palatal aspect, with no damage of the incisal edges, as you can see here. So the treatment for this patient in the palatal area will be direct or indirect palatal composites. So what will be our treatment plan? We will have 3 steps in our interdisciplinary treatment plan. It will be orthodontics, it will be also palatal composites, and at the end, we will need also to restore these aesthetics, closing these diastemas. But is this going to be our timeline? First ortho, second palatal composites, and third diastema closure? Or we are going to use another or a different order of these steps? We are going to use at the beginning the implementation of palatal composites. Our second step will be orthodontics, and at the end we are going to close the diastemas. Why? Because if we remember the first extraoral pictures, we can see that the incisal display is correct, because the incisal display is defined as the amount of the upper central incisors shown when the lips are addressed. So the determination of the lengthening of the tooth, if we need to lengthen them, it is going to be defined by the incisal edge or from the gingival margin. The ideal incisal display, it's between 2 and 4 millimeters, depending on the age of the patient and the sex of the patient. In a male, in a young male, between 2 millimeters, 3 millimeters, it is going to be the ideal incisal display. So if we go again into the initial extraoral pictures, we can see that our incisal display is correct, and also that our smile line, it's convex, so it's correct again. That's why we are not going to try to correct our overbite, our excess of anterior guidance with the intrusion, with the classical management. We don't want to do an anterior intrusion, because if we do that in anterior intrusion, if we would keep that classical management, we can achieve this kind of treatment. We wouldn't show any incisal display anymore, and we would achieve a smile. So what we try to implement is the Dahl principle with the posterior extrusion of the teeth, trying to, as I said, implement the Dahl principle, but not with metal devices, but with palatal composites. As you can see in the draws, we will place some palatal composites in the palatal side of the anterior superior teeth, and we will achieve this open posterior bite. The orthodontist, this is the restoration of the palatal aspect of the teeth, just with nanohybrid composites. Any kind of nanohybrid composites or microhybrid composites will be nice, not flowables. And this is the first step of our interdisciplinary treatment. We restored these 4 anterior teeth, palatal aspects of the anterior teeth, and we will achieve this open posterior bite. So we will send it to our orthodontist with this occlusion, and the orthodontist will try to do his posterior extrusions with this kind of wires. It's an Australian wire to rise. He will try to rise his this vertical dimension. So with no anterior intrusion, he will achieve to close that posterior open bite. This is 15 months later, after our first step in the interdisciplinary treatment of the restoration of the palatal aspect of the anterior superior teeth, and the second step of the orthodontics with the posterior extrusion of those molars. And the third step, we have to close these diastemas. In that time, I asked my orthodontist to place the incisor laterals mesially, but right now I would ask him to place the lateral incisors in the middle part between the canines and the central incisors. Why? Because if I've got this space here, I will need 3 layers of composites at least to achieve a good result, which is opaque layer, medium dentin layer, and enamel layer. If we choose another kind of situation for these lateral teeth, we will just need 1 or at the maximum 2 layers of composites. And that will be more easier, or will be easier for me. So this was the kind of result I achieved. It's not my best result, I know, because I had to place this opaque and try to not to show it too opaque. So I know it's not the best result I can achieve. That's why now I'm trying to ask the orthodontist to place it in the middle side, so I don't need to use opaques here. Just medium dentines in the distal part and medium dentines in the incisal part. So when your ortho asks you as restorative dentistry, where do you want him to leave the lateral incisors, always tell him leave it 50% mesial, 50% distal. This is another case where I ask him to do it. Let the lateral incisor in the middle between canine and central incisor. I just have to place some medium dentines in the mesial in the distal part of the laterals. And that's what I did here. Just a medium opacity composite, a dentin composite, not opaque composite, not as enamel composite. And this is the result we can achieve with just 1 layer. It's easier to achieve it and more natural when we see it also. You can see or you can consult this article from Sarati and Giovanni Tommaso Rocca, which is published in the Journal of Prosthetic Dentistry, to keep this technique. Coming back to our patient, we also need to restore the lower incisors, and we did just a simple layering technique with composites, 3 layers of enamel, dentin, and some opaque dentin in the incisal edges. This is the initial situation before ortho, second step after ortho, and the final result is not the best result. I know Professor Serhat Koken can achieve better results than me, but this is what we did with Polarize. And this is the end of our interdisciplinary treatment. Just keeping in mind from the beginning what was going to be our treatment plan, and always communicating our objective and sharing our objective between the ortho and the restorative dentist. Look at this picture. This is the baseline of our treatment, nice incisal display. And this is the final extraoral picture, where we can see we have the same incisal display, which was correct at the beginning of the treatment plan. So we can also see our initial smile line, which was also correct, and our final incisal, our final smile curvature, which is also convex, and is the objective when we are looking for aesthetics. This is our patient at the end of the treatment. And the key points of this clinical case: if we don't have wound dentition, we have to avoid, if we don't have wound dentition in the posterior area, we should avoid to restore with material to rise the vertical dimension. We have to extrude that posterior dentition. And the other key point, if our incisal display is okay, don't move it unless compensatory extrusion is present. And we will see it in the next clinical case. We are going to see another easy movement and very used in our daily work, and which is the management of the anterior guidance and the zenith equilibration. Adrian, who is a 23 years old patient, was complaining about his dentinal hypersensitivity. As we can see intraorally, we can begin to think that something wrong is happened looking at these incisal edges. We have a correct posterior occlusion, but if we go to the occlusal part, if we go to the occlusal view, we can see that there was also in the posterior, not only in the anterior area, but also in the posterior area, that for sure we will be having some erosion. And also in the lower arch, we are having in the posterior area erosion. Also in the anterior area, we can see attrition. How can we, from an objective point of view, say that there's attrition or erosion? How can we say that there's a tooth wear? Because the tooth wear was estimated for the maxillary central incisors of 1 millimeter, and for the mandibular central incisors 1.46 millimeters at the age of 70 years. At the age of 70 years, the normal tooth wear has to be 1 millimeter for the superior superior incisors and 1.46 for the lower incisors. So, of course, in the actual patient, we can say that we have tooth wear, not only in the posterior area, but also in the anterior area. And if we want to compare it with our first patient, this is the actual patient, and this is our first patient I present before. We didn't have tooth wear in the posterior area in the last patient, but we have tooth wear in our actual patient. So our treatment plan will be different, and we are going to implement our goals. In this patient, we will have to eliminate chewing dentinal hypersensitivity, as in our first patient. We will have to prevent future excessive dental wearing. We also want to restore an efficient anterior guidance. And of course, we want to improve aesthetics. There was not a real problem of aesthetics in this patient, but for sure we will create it. But having in mind, we will have to restore it again. So our treatment plan, first of all, will be the restoration of the posterior wound dentition to eliminate chewing dentinal hypersensitivity. We will also use the orthodontics to prevent future excessive dental wearing and to re-equilibrate gingival zeniths due to compensatory extrusion. And we will have to restore the anterior wound dentition to restore an efficient anterior guidance and to restore aesthetics. And how are we going to implement this treatment plan? So the first step here will be different of our first case, because the first case will be restore these posterior eroded teeth. So we are changing our treatment plan compared with the first patient. I will restore it with direct composites, just one layer in the posterior area, no more for me. This is the material I used here. I usually use universal adhesive or a two-step adhesive with parodont system if I need to restore a class 2 proximal boxes, and flowable composite and a nano hybrid composite on the top, and some tins if I want to mimetize the restoration with the rest of the mouth of the teeth. So our first step, this is a baseline. This is our first step after restoring the posterior teeth wear. We increment we rise the vertical dimension, and we will send it to the orthodontist in this for his work after restoring with composites this posterior eroded teeth. So why I am going to restore it with composites? Because as we can see in this publication, composites are not going to perform as an enamel, but they are going to perform better than exposed dentin. So we are going to protect that dentin if we in the more conservative way, if we restore this eroded or treated teeth with composites. The pool data in this publication show us that the wear ratio between the enamel and the resin composite was 2.5. This implies that patients in need of treatment to restore the vertical dimension will require retreatment after 5 to 10 years of treatment. But if we implement occlusal splint, that will be longer. So for us, composites are a nice material to restore this kind of eroded teeth. So in the second step, orthodontics, Nacho, my brother, will try to re-equilibrate the senites, and the other thing he's going to try is to re-equilibrate also the posterior bite with the ortho. So you as restorative dentists don't have to worry about your occlusion, because the ortho will fix it after your restorations. At the end of the ortho, we have an equilibrated anterior senites, and we also have a nice posterior occlusion. This is the beginning of the treatment of the ortho plan of the ortho treatment, and the finalized ortho treatment. This kind of movements, this kind of intrusions in the anterior area, as we can read in this article of Vincent Cockett, they are not going to they are not going to reabsorb any alveolar bone, and they are not going to reabsorb more root of the teeth than any other orthodontic movement. So it can be used to help us as restorative dentists in an interdisciplinary treatment plan. So this was our lower arch at the beginning of the treatment. This is after our first step of restorations of the eroded posterior lower teeth, and this is the end of the treatment after the first step of restorative treatment, orthodontic treatment, and giving it to finalize the anterior aesthetics. This is the space the ortho give us after the treatment. And now we have to think about restoring this anterior guidance. Of course, we can do it with composites, but we chose here to do it with ceramics, placing 2 veneers with minimal preparation in the central incisors. So now we have to reevaluate our patient and see that, of course, we need to restore that incisal display, and we have to change our smile curvature, which now it's concave. We have to do it convex. And of course, we can do it analogic or we can do it digital, but you don't have to do it. You don't need your flux always digital, or you don't need it analogic. You can choose and go inside and outside of that digital flux in the moment you want. So that's what I did here. I did a digital planning with intraoral scanning, sending it to the lab. They did a virtual wax up, as you can see here. They print the model and they send that printed model to us again. We did wax up silicone key and put the mock-up in the mouth. This was our mock-up in the mouth. We again reevaluated. Now, this is a perfect incisal display for our patient and a convex smile line again. So we can go and prepare our teeth. As you can see here, that's our preparation. And again, for the fabrication of the restorations, we have to choose between digital. We can do it mostly digital, full digital, or partial digital. And we, again, did it mostly digital. We did an intraoral scanning after our preparation. We send it to the lab, and they print the models. Why did they print the models? Because I want feldspathic veneers, and I want them handmade, so they need to work on a model. If you go to work with CAD/CAM veneers, you will not need any model, any printed model, so you can do it, your fabrication, with a full digital flux. This is our fitting trying with no cement. We are not seeing here, we are not trying to see the color. Just fitting with no cement. And after that, we can go to the cement trying. I don't like to use the cement trying as we have it in the kits the commercial gives us. I like to use the real cement with no polymerization, because we know that we can't find many times agreement between the trying pastes and the corresponding luting composites. So this is my protocol for cementing veneers: hydrofluoric acid, 9% between 60 and 90 seconds for feldspathic veneers. After that, I wash them with phosphoric acid, and I place some silane. I use just a two-step etch and rinse adhesive, and I use also calibra veneer for cementation. The conditioning of the teeth is the basic protocol we all know. Orthophosphoric acid on the enamel, again adhesive, and I like to place the luting cement on the teeth and also on the veneers. This is our case finalized intraorally. Correct posterior occlusion and correct anterior guidance. Initial of the case and finalization of the case, and our incisal display after the interdisciplinary treatment plan. You can see we have again our convex smile line. And this is the extraoral evaluation of our patient. We also do an evaluation, a dynamic evaluation, not only at the end of the treatment, but also at the beginning of the treatment. And to finalize my presentation, just one more case. How can we implement the posterior intrusion to create occlusal space? As you can see, we have a patient with a normal occlusion with no problems. As we can see, maybe some tooth wear here. She's a 60 years old patient with non-generalized dental wear, but complaining about this area. There was, for the age of 60, 70 years old, there was not pathologic or posterior or anterior tooth wear, except in this area, the area she was complaining about. So what can we do here? If we don't have generalized dental wear, we cannot rise vertical dimension with a full mouth rehabilitation. We have to restore only the area she was complaining about. So what can we do here? At the beginning, I think you are thinking about the same I thought in that moment, that was we can seal with some gluma maybe, but that's not a long-term treatment. We also can put some crowns, but that's not a conservative treatment. And also we can put some overlays, but we can, I think, do a more conservative treatment. So I called my brother and I told him I need occlusal space. So he told me, okay, we can use micro screws. And how did he use that micro screws? He placed one micro screw in the vestibular area of this patient. As you can see in the radiography, he placed one micro screw in the vestibular area between 4.6 and 4.7. And with this splint and some elastics, he intruded these two molars. And after 3 months, 4 months between January 2018 and April 2018, he achieved occlusal space for me just to place some composites and just to perform 2 class 1 composites in this 0.46 and 4.6 and 4.7. This is what I did in the second step. Just some composites, one layer, select enamel edge, and some flowable composites. And on the top, microhybrid composites to achieve this result. This is the baseline, and this is the final situation after one step of orthodontics and the second step of restorative dentistry, simple restorative dentistry. This is the baseline after orthodontic intrusion and after direct restorations. This is the occlusal space the ortho, my brother Nacho, gave me to just gain some occlusal space, and this is the final situation after just 2 composites on those 2 molars. So thank you very much for your attention. Thank you, Serhat Koken, Turkish Study Club. Thank you, Istanbul Kent University. It's been a pleasure and it's been an honor. If you want to see some more cases, you can follow me in Instagram, or you can follow my brother, Tito Faus, on Instagram, or you can write me through Instagram, and I will be pleased to answer you with all your questions. I will stop sharing my screen. Thank you very much, Professor Semnek Turkum.
Thank you very much, Dr. Matoses. It was a really, I mute?
Yes.
Thank you very much, Dr. Matoses, for your amazing presentation with the beautiful cases, showing us the cooperation with ortho and restorative dentistry. That was really amazing. Thank you very much for this nice presentation. So many people are thanking you for these nice pictures and nice cases. I would like to ask you, the first and second cases that you were showing were really young patients that could accept orthodontic treatments. So when we have much older people that don't want to go for a 1.5 year of orthodontic treatment, what should we do as a procedure to maybe to open the posterior part of the occlusion? Maybe what do you think about tabletop restoration or doing some composite restoration on the top occlusal surface of the molars? What do you think about that?
Well, that's a problem. I was trying to say why not to do it, but of course, not all the adults patients accept orthodontics. We just try to explain them that if we are not going through ortho, the treatment plan will not be so conservative, and the survival rates of the pulp will not be the same, and at the end we will have maybe some problems with that vitality of the teeth. So we try to change their minds and put them into ortho. But of course, if they don't want, minimally tabletops are fine. I prefer direct composites, but of course tabletops are not a bad treatment plan.
It's also maybe more shorter treatment time than ortho.
Of course,
we have the result much earlier.
Of course, it's a shorter time. That's for sure. That's for sure. But maybe the lifetime of the teeth is not the same. I mean, it's a philosophy. Of course, I agree 100% with you, Professor. But we try to change that mind, and we try to go into the ortho to be more conservative. That's all. We know we have some chances, but
But
That's what we try to.
Totally right. It's more conservative, and especially for young people, it will be. It will really increase the lifetime of the occlusion. Also, it's more conservative on the long term. It's more conservative. And there is another question about your last case with the microscrew, orthodontic microscrew, that you were intruding the molar. So I'm not an orthodontist. I really don't know.
Why?
Yeah, how it works. You know, you put the microscrew into where, actually? In the periodontal places, or where did you put it? Is it painful? Did you do anesthesia or something?
Yeah. In fact, actually, we don't need to put truncular anesthesia, because the only pain we can feel, or the patient can feel, it's with the periosteum. So we can just infiltrate in the area we are going to place the microscrew, and we put it into the bone. The bone has no nerves. I mean, more than the the dental nerve, of course, but not the main branch of the nerve. But we cannot. He's not going to feel any pain. Just and of course it is going to help us to know if the patient is feeling pain, because if he's feeling pain, we are touching the periodontal ligament, and we have to avoid that. We have to place the microscrew between the roots of the 4.6 and the 4.7. Just go between one and the other one. And the anesthesia, as I said, has to be infiltrative, no truncular.
Okay, just the last question about that. After your restoration, it's very good intrusion, and you can do your occlusal restorations perfect. Look, the results is perfect on the restorative point of view. However, there was a really like a kind of trauma in the gingiva. On your pictures,
I will. Very nice question, because
when it will disappear and the gingiva will get healthy again.
The healing of that gingiva, it's almost immediately, and it was because in the same session I was pulling out the microscrew. I have to restore with the composites, and that was why you see that it was hard, because if you take out the microscrew and you send it to your restorative dentist 15 days later, for example, you will have a relapse. So the day you take out your microscrew, you have to restore and give a stabilization of the occlusal space with the composites. That's why I have some blood in the pictures. I don't know if I'm answering that question.
Yes, perfectly. Maybe on the long term, the gingiva will get healed maybe in 6 months or something, I guess.
No. Just 4, 5, 10 days. No more than 4, 5, 10 days.
Okay. So thank you very much, Tito Faus, for your very nice presentation, and enjoy the rest of the program. Okay, I'm closing.
Thank you very much.
Thank you very much for being with us live today. Thank you.
Very honored. Thank you.
Goodbye. Thank you.